Hi, and welcome to Dental XP. Sometimes we have clinical situations like the one that we are seeing behind, but the thing is that do we really know how to treat it? What I will try to do with you all is to share my experience and to give some topics to you to understand and to treat these kind of situations. The thing is, do we first treat the periapical issue? Do we do the extraction and immediate implant placement? Or do we do a delayed procedure? Do we install an immediate provisional? Do we left the side like this one? Do we install the implant and we install immediate provisional? Those are the questions that I will answer in the next 15 minutes. Controlled soft tissue management of an extraction site for delayed implant placement. That is the subject of our topic today. Well, this is a patient with a partially edentulous jaw in the upper and in the lower jaw. The subject will be related to this one, that is the first premolar upper jaw, tooth number 12 or tooth 4. We obviously can see that we have some other topics in the same jaw, but we will refer to this particular case because we all know that we have to install an implant here. But the real and the major question is how we do it. We do the immediate extraction and implant placement, or we do a delayed one. We are seeing in the red arrows the retraction of the soft tissue. When we have that, we have to understand that in the bone we could have some problems. And if we have papillas, then we will do another way to face it. I mean, another way, we will not raise the flap if it's not strictly necessary. When it is strictly necessary, when the problems in the bone, like the one that we are seeing right now, the periapical lesion, it compromises the vestibular or the palatal plate. In this case, it's just remaining in the apical part. What is important to have in attention is the sinus extension and, of course, the bone at the marginal level in the mesial and in the distal aspect. That would let us understand how much or how many bone do we have to install our implant. And in this case, having the correct selection of our implant, we will have more or less 15 or 16 millimeters to install a good diameter implant. For this case, a 3.8 implant. The question is, as I told you before, how we do it, how we place it, how we face this case. Well, the way that we do this in particular case is that we will do first the extraction, and then after 1 or 2 months, we will do the implant placement. This case, this patient, we treated with chlorhexidine first and also with antibiotics. So that stains are not for smoke, it is for chlorhexidine, but it will may confuse you with some decay problems. So we have to clean our mouth to be very sure, like this. It's not a chlorhexidine stain, that is a decay problem. So the thing with this patient is that we will do the extraction and we will hang on a provisional or a temporary crown filling to the filling material in the second premolar. So the third thing that we will do is to remove the caries and also remove the filling material, the amalgam. And once we were finished that, we will then make the extraction. Why? Because when we are using our turbine, then we will create a spray that could contaminate the site of the extraction. So first we will do the removal of caries, and in the second place we will remove the rest of our tooth. For that subject, we will use periostomos and very gentle tooth extraction without compromise the papillas. Of course, we have to clean the socket with the curettes, and after that we will proceed with the suture, a very gentle suture for not to compress the bone and the soft tissue. Remember that we are trying to preserve the papillas. Once we finish that, we put our rubber dam, like we are seeing right now, and with that we will isolate the wound, and also we will isolate the tooth that we want to fill and to hang on that the new crown or the provisional crown. For that, we must proceed like in the very strictly way of a filling process. Once that we will select our provisional crown, we have to be very careful about the contact point that we are seeing in the round marks, and we have to be very precise in the length of the new crown. With that in mind, we test our crown and we fill it with the new material, with the temporary material, but we have to prepare the relation with the cervical part or the gingival part to do a very rounded pontic, like a classic pontic in the fixed prosthesis, the intermediate crown, but in this case we will put it as a guided of our healing process to preserve our papillas. Which is very important, like I said, is to preserve the contact point and to make a little pressure inside the wound, the socket, and go further inside with the provisional material, like we are seeing here. That will let our gingiva to release over the new crown, and in that way will heal in a proper way, without pressure, and with the preservation of the papillas. That is the thing that we wanted to have here. As I said before, it's very important to have all the protocols of the classic dentistry to preserve a good contour around the new gingiva and of course around the new filling process. Once we remove the rubber dam, we will see something like this, without sign of ischemia. That is quite important, and of course that blue line that is the suture. After 1 week, this is the image that we will have, and we have to be very careful with this image because it's there is a little bit of inflammation, and we could feel very satisfied, but that will be retracted a little bit if you want. But we are in the correct way. After 1 month, as you can see here, there is in the mesial papilla a little black triangle that we may correct in the future with the correct crown anatomy and of course with the correct implant installation. We have to be very careful with the distance of the contact point to the bone, as the papers of Dr. Tarnow says. Also, he do it in the classic paper of 1992 and in 2001 with the implant relation and the tooth beside it. Which is more important right now is the periapical lesion. We have predisposing conditions for retrograde peri-implantitis that was very well described by Daniel Van Steenbergen and Mark Quirinen in one article that you are seeing right now. And after that we treat that with the extraction and the correct curette of the socket, we have this situation. After 1 or 2 months, this is the new image with the papilla in the correct position and absolutely preserved, and a good relation to the adjacent teeth. Right now, we have to decide which kind of implant we will use for this socket. So we make some little measures, and then we start to prepare the bone to receive the implant. For this purpose, we will use tissue punch or around the vistry in order to preserve the papillas and not to raise a flap. Sometimes, like in this time, the best flap is the flapless procedure. Why is that? Because we have, like we are seeing in the red circles, some retractions, and as I said before, when we have those signs, maybe we have some problems in the bone. So we have to be very careful if we are not very skilled in those sutures and microsurgery. Right now we are seeing the procedure to prepare the bone. This is the extension drill that is quite important to avoid, to keep in touch the head of our contriangle with the crowns of the adjacent teeth. And that is the implant with the side already prepared. In the Biohorizons protocols, we have two ways to install implant. One way with the implant driver direct to the implant, and one way with the implant driver direct to the abutment that came with the implant. We can go with the handpiece, or we can go with the torque wrench instrument, like this case. When we are installing the implant, we have to do some slight movements in forward and backward or in a lateral way, searching for the best position in the space for the implant, like we are doing in this moment. After that, we can go with the ratchet, like this one, and we have to be very careful with the space remaining to the adjacent teeth. We have to avoid any touch of any instrument when we are installing our implant, because it could tilt in some way the implant, and that could end in a position not so adequate to the final crown. So once we finish our implant placement and we are okay with that position and we are very satisfied, we have to be very careful about the position of the implant in relation to the adjacent teeth, in relation to the length of our abutment, in relation of the bone limit, and in relation, of course, at the implant surface, like we are seeing right now. In red, we have the bone, in green, we have the implant, and in yellow, of course, is the zone that will be occupied by the abutment. With that topics in mind and very clear, we are sure that we will preserve the papillas. Now, with the new provisional, in this case directly to the abutment and directly to the implant, we have to preserve the contact points like we are seeing right now, and we have to be very sure to select the adequate crown to be adapted in a proper way to the abutment, and to avoid the overpressure to the soft tissues and to create ischemia. Once we fill with the filling material, we have to be very careful to give the correct anatomy to that crown. Even though it's temporary, it should be the best anatomy that we could perform to our patients. We trim it in a proper way to eliminate any inadequate anatomy and to give a smooth surface. What we are seeing right now is a little trick. It's a little hole in the palatal aspect to let the filling or the lutein cement escape from that camera, and in that way the lutein cement will be out of the soft tissues like we are seeing here. That is a very good option of treatment, and that will ensure that the soft tissue will heal in a proper way without any foreign material like we are seeing right now. The little black triangle will persist until we go with the definite crown, because in the definite crown we will be able to give a longer contact point, a better tooth anatomy, etc., etc. What is very important is not to forget that we are doing an immediate crown placement, an immediate connection, so we have to avoid the contact of that crown in the lateral movements and also in the interocclusal relation with the opposite jaw. And with that issues in mind, we can pass from the situation that we are seeing on the left side to the right side. And after a period of 2 or 3 weeks, we will be able to see this kind of situation. It means that that crown is over an implant and we are recovering the papilla, or we are reducing the little black triangle that we saw it first in the hanging on provisional. This is the image of our implant with enough bone surrounded it, with good bone in the mesial and in the distal aspects, and also prevented to be filled or fall into the sinus. Also, it's very important that the crown material for filling is out of the gingival spaces. As we are seeing here, that is quite good image after 1 month, and this little black triangle is reducing every day more. Now we can feel very satisfied about our treatment and the way that we do it. As I told you before, Dr. Tarnow's papers let us know that even though we are treating natural teeth or teeth over implants, the same relation from the contact point and distance to the bone is in implants and tooth. Well, that is the thing that I want to share with you. Thank you very much to see it.